presenter today has been working in the medical field for over 30 years. He has been active in R&D, imaging systems, and projection radiography, specializing in image processing algorithm development. He started and led medical imaging processing group at Kodak. He was a member of the team that commercialized the first CR system. He's been responsible for pre- and post-sales support for digital imaging solutions, including project planning, training, and clinical optimization. He has also helped other vendors with new leading-edge imaging technology. He's currently working with Carestream in both product marketing, standards, and regulatory roles. He has also published numerous papers and book chapters and holds 6 patents in the medical imaging field. I am pleased to introduce our speaker for today, Dr. Ralph Schaetzing.
Thank you, Jim, for the nice introduction. A simple question: does image quality matter? And if we were all sitting in one room, I would now ask people to raise their hands to answer the question. Since we're not doing that, I'll go on the basis of past experience where I've given this talk 2 times before, and practically every hand in the room goes up because people think image quality does matter. And it's not unusual. I mean, we look at images every day, so we make judgments about them, and those judgments often refer to image quality. So what I'd like to do at the webinar today is ask 3 questions, and hopefully answer them, about image quality. What is it? Where is it? And who cares? And we'll do a quick summary at the end. As I mentioned, everybody has an opinion about image quality. We show an image to someone, and there'll be an opinion about whether it's a good image or a bad image, or if we compare 2 images, or as in this case, 4 images, people will tend to pick the image with the best image quality, because we're brought up looking at images using certain criteria that are in our brains. So if we look at these 4 images of tiger swallowtail, butterfly, they have different characteristics. And so if I ask you which one of them has the highest image quality, the answers will tend to focus on the right side of the page. Either the upper image on the right or the lower image on the right, whereas the images on the left will get rejected for various reasons. The original image is in fact the image on the upper right. The image on the lower right has been color corrected, has been saturated a little more to make it look more appealing, which is why some people pick that image. But in fact, the original image is in the upper right. So we have these criteria in our brains that we use to decide whether an image is good or not and which image is better. Those criteria work even in cases where we have no idea what the image is that we're looking at, which may be the case with this image. This happens to be a non-destructive testing image of an airplane wing with some debris inside and a piece of tape and some water. Even here, if you look at the images for a while, you'll see certain characteristics that will distinguish one image from the other, and that will lead you to make a conclusion about which image has the better quality. In this case, the original image is the lower right. The one above it has been contrast enhanced a little bit, and the one in the upper left has been sharpened a little bit, but also had some noise added, and the other one is unsharp. So we use these criteria in our minds to decide which images are better and which images are worse. And we do the same thing in medical imaging. In medical imaging, we have a chain that consists of 5 functions. There's the function called capture, where we create a digital image. There's a function called process, where we do some manipulation of the image. And there's a display function. That's the main part of the chain. And then there's a share and distribute function that allows us to move images around. The process piece is actually a little more complicated. It's actually 3 pieces, one of which goes to pre-process the captured image, and I'll show you what that means a little bit later. The other piece is the one that we usually think about when we think about image processing, and that's optimization of the image, making the image the best it can be for a human viewer, assuming we have a human viewer. And then there's processing for display, which we'll also talk about a little bit later. When you see this chain, and think about the questions I asked at the beginning, the question is, where is image quality in this chain? Is it during the exposure process? Is it in the detector? Is it after pre-processing? This is what DICOM calls the for-processing image. Is it the optimized image that comes out of processing, the for-presentation image? Is it the image that goes to the display? Is it the image that's on the display? Or is image quality something that's in the viewer's head? It's not an easy question, it turns out, because image quality is at multiple places in this imaging chain. When we talk about image quality, we talk generally about 2 kinds. We talk about detector quality, and we talk about the quality of the image, the quality of the displayed image. And of course, there's a connection between those 2 kinds of quality. The connection is furnished by exposure technique. That is, what do we choose as KV, MAS, filtration? In particular, what do we choose as the dose for a particular image? And the connection is through image processing. How can we take the image that comes off of the detector and make it better so that the displayed image will be one that the end user can actually use for some task? So the choices we make during exposure and image processing determine to a large extent how we turn this detector image with a given quality into a displayed image with a given quality. It's possible to produce poor images using a good detector. It is equally possible to produce good images from a poor detector. We have to be careful how we define good and poor, but it's not always obvious that if we have a high-quality detector, we will get high-quality images out. There's some work to be done in order to make that happen. So if we go back to the what is it question, there are actually 3 kinds of image quality, not just one. One of those kinds depends on objective physical characteristics, things that are intrinsic to an imaging system that you can measure in a laboratory independently of an observer. So that's one kind of image quality. Another kind is subjective. That is, image quality is whatever the observer says it is. That's the exercise that we went through right at the beginning of the talk with the butterflies on the NDT image. If you tell me that image A is better than image B, then I have to believe you. I may think that image B is better than image A. It's a subjective image perception. And finally, there's an image quality that's defined by performance. It's defined by the observer's ability to achieve acceptable performance for some specific imaging task, finding round nodules or whatever. These three kinds of image quality, unfortunately, are very weakly correlated, if at all, at least for imaging systems today. What that means is, if I know the objective metrics of a given imaging system, I can't predict performance of a human observer. There have been cases in the literature where the objective properties of an imaging system have improved, and the performance has either not changed or even gotten worse. The same is true for the other side, for the subjective metrics. Just because a radiologist says, I prefer image A to image B, doesn't mean that the radiologist will perform better with image A compared to image B. In fact, it may be just the reverse. So the relation between these three kinds of image quality is very weak. That's an important point that we'll come back to later. There are a few thoughts that we can inject at this point. Each of an imaging chain can either maintain or degrade the objective image quality of the previous stage. Can't make it better. Remember, this is the objective image quality, not the subjective. We'll talk about that as well. It means that the highest possible image quality that you can have in that imaging chain is the inherent image quality in the X-ray image, as it's called, that's coming out of the patient before it hits the detector. In other words, the detector is the first degradation in the chain. Inherent image quality, as we saw, is the result of the exposure conditions we chose, KV, MAS, etc., how we put compression, and of course the patient. Imaging is the constant battle to save as much of that inherent image quality as possible. And in order to do that, you need tools to figure out how much is left. And those tools are familiar ones, at least some of them. Contrast, resolution, sharpness, and noise and model. Those three basic tools we use, and you used at the beginning of the talk, to determine which image had better quality. Now, being a physicist, we tend to use fancier tools, and I've listed some of them on there, and they all have acronyms in order to keep out other people so they don't know what we're doing. MTF, SWR, SNR, CNR, NPS. You see them all there. The big one these days is DQE, detective quantum efficiency, and I'll say one more word about that in a follow-on slide. But there are lots of tools available to try to measure the objective image quality. We have the image here. Anything else present in the aerial image that are not captured here are gone. Imaging can't help you recover those details. So you need to do a good job. You need to have the objective image quality available in order to capture the details necessary for the task. So these objective image quality metrics that I just showed you on the previous slide come into play here. And for digital detectors like CR and DR, pre-processing is required. One point that's underappreciated is that digital images are invisible. You cannot see, and you will never see, a digital image, because a digital image is simply a collection of numbers stored somewhere in a file. It's only send that image to an output device that you can make it visible again. And that output process, we'll talk about a little bit later, has its own problems associated with it. Right now, we want to make sure that we capture the details that we need. So on the detector side, we have a tube where we can make lots of choices, and we have some level of beam quality that comes out. We go through a patient, and coming out of the patient is this so-called aerial image, or the image in space. This is where we have the highest possible image quality. And under certain conditions, we can actually calculate that image quality. That aerial image strikes the receptor, produces an image in the detector, which has slightly lower image quality than the aerial image. DQE is nothing else but a measure of the quality of the detected image to the quality of the aerial image. That's it. Right? That's a way of looking at DQE. There are lots more complicated ways, but then everybody would drop off the webinar, and so I won't go into those. Processing. What you see on the left here is a raw image from a DR detector. No reference is from the year 2000, so this is a very old detector, very early DR detector, and you can see there are lots of problems in the raw image. There are missing lines, missing pixels, non-uniform backgrounds, all sorts of things. So this image, before a human being is allowed to even look at it, has to be pre-processed. Processing consists of a number of different steps. One of them is called gain and offset correction. You can see that the non-uniform background has been removed, and a few other things have gotten better in terms of contrast. And the correction for bad pixels and lines. Now, in this particular detector, you notice that in one of the fingers, there were multiple lines that were dead next to each other, and it was not possible to correct that out. Gotten considerably better over the years. So these kinds of images don't come out of modern-day DR detectors, but we still have to do pre-processing because there are non-uniformities, there are still dead pixels and lines that all have to get corrected out before we send the image further down the chain. So let's look at these metrics in turn: contrast, sharpness, and noise. You'll see this a number of times as we go through this talk. It's called a 4-alternative forced choice experiment. It's a name for basically finding the target in the image. So there's one in the center, always, and there's one at one of the 4 corners of this diamond, or the square, depending on how it's oriented, and you have to guess or determine where the corner circle is. Now, for the target that's on the screen, it's a relatively simple task. If I make it a little more difficult, this is where you now have to point to your screens and tell me where the corner circle is. Since I can't see anyone, I'll just tell you where it is. It's on the right side. The difference between these two images is contrast. The target is exactly the same size, but the target on the right has a far lower contrast relative to its background than the target on the left. Digital images, we have discrete quantized signal levels. No signals in between. So if we look at this graph here, we have an analog input, the image that's coming out of the patient, that goes between some minimum value and some maximum value. We break that range into bins, and each bin gets mapped to a number. That's collation. The one that's shown here has only 8 levels, which turns out to be a 3-bit quantizer. But when we're doing it for real, with medical images, we need enough signal levels, that is, we need enough of bit depth, as it's called, and the proper shape of the quantizer, There are 3 kinds that are used on the market, to make sure that all these differences in the medical image are recorded faithfully. See in the image on the left here that they're not here. You see these steps, these little islands, because there aren't enough bits used to represent that image. Processing can change signal contrast only if these signal differences are captured. If target is different enough from its background, as you see here with the letter C, where the difference is 10 code values, 10 gray values, that image processing can help to raise the contrast when the image is displayed. Here you see an image where the difference is only 2. If your monitor is reasonable, you'll still see a difference between the letter C and its background. You'll also see that the letter C is no longer pointing to the right, it's actually pointing up. On the left, where delta is equal to 0, you won't see. And image processing won't either. Right? So this concept of contrast is very important in order to be able to display the image later with the appropriate contrast for the human observer. What about sharpness? Here's the same target again. I've turned it in a different direction this time, so the corner circle is in a different place. The left image is the same one as I showed you before, just turned. The right image, I have blurred the target that we're looking for, the circle, maintained its overall contrast. And it's harder to see. It's there on the left side. Sharpness plays a role in this process too. It's not just contrast. A number of loss mechanisms in the beam path of a radiography system that reduce spatial resolution. The focal spot itself, detector element size, how we do our sampling process, scatter, and other factors. What happens in that process is that small structures, the finest details, are usually blurred more than the large structures. So the losses that we incur are spatial frequency dependent. You can see that in the butterfly image. The lower image is the blurred version of the upper image, and you can see that the finer details tend to disappear first, whereas the coarse structures in the wing are still there because they're at a lower spatial frequency. Finally, there's noise. None of this imaging process goes on without noise. So the structure on the left is easy to see because its contrast is high enough. But if I want to find the circle, the corner circle, in the right diamond, it gets more difficult. It is similar to the image we looked at before in terms of contrast, but I've now added noise, which makes the structure more difficult to find. So noise plays an important role in this whole process. What you see here on the top is a screen film system where we have no image processing other than the shape of the curve that's defined for a particular screen film system. And on the bottom is a DR system where we do have the possibility to do image processing. Dose increases from left to right, which means that image quality metrics like signal-to-noise ratio and contrast-to-noise ratio improve as we go from left to right. And you can see that because in addition to these point-like structures, high-contrast point-like structures, there are rings in this image, low-contrast rings. And as you go towards the left, lower dose, the ability to see those rings decreases. With higher dose, we can see them. With lower dose, we can't. With the film system, As we go to higher dose, we have an additional problem, namely the curve itself starts to flatten out. Our contrast decreases. So screen film systems are contrast-limited systems, whereas digital radiography systems are noise-limited systems. Now, of course, we don't want to go to the right in imaging. We want to go to the left. We want lower dose systems, and that's the trade-off we have to make. We have to see how low can we go with the dose before we start to lose the very structures that we're trying to find. That's the image quality dilemma when we're looking at imaging. What about the other side, the display side of the system? We have a digital image, and we want to make the digital image visible again. And we want to make it visible in such a way that the relevant clinical details are there for the human observer. And if we've got a machine reading the image, we have a different problem, like doing CAD. But here we have a human sitting at the end of the chain. And the way we can do that is through the use of so-called adaptive image processing that reacts to the characteristics of the image and adjusts its parameters in order to make the image look good. And we need a well-characterized display at the end. We'd also like to have consistent image presentation. We would like the image to look the same on different output devices, and we would like it to be relatively independent of viewing conditions. So this is where the subjective and performance-based image quality metrics become more important. This is the PACT side of the equation. Image processing. The optimization of medical images has been around for more than 50 years. So R&D has been going on throughout that time to create tools and techniques to make changes to images, in particular changes to global and local contrast, to spatial resolution, to noise, in order to make the final displayed image more interpretable, to make the interface between the image and the viewer better. For all companies who work in this business, there's a common clinical goal. That's to optimize this interface. And all manufacturers use some of the same basic processing tools that are in this toolbox, but also develop their own variations, their own innovations. And it's an ongoing R&D investment to optimize image processing algorithms for various detectors. There is, at the moment, little regulation, little standardization of medical image processing, and I would argue that's perhaps not even desirable, because you do want to find out how do you optimize this interface the best way between the image and the observer. So this is an ongoing activity with standards organizations around the world trying to figure out what, if anything, to do with image processing. If the detector piece and the display piece are reasonably well characterized, and there are standards around that define how they should be handled, but the part in the middle is trickier. So we've captured an image, we've optimized it in some way, and we've produced an invisible matrix of numbers. Our digital image looks like this thing on the left. It's just a bunch of numbers in a file. So we have no idea what we're looking at when we look at those numbers. We have to send those numbers to an output device. That could be a monitor, it could be a laser printer, it could be an iPad or a phone, and then we have a human looking at the image that comes out. That brings up a number of questions. The device that makes the output image needs information. It needs to know how big is the matrix with the numbers in it. It needs to know what the numbers mean, how many there are. Is it one number per pixel, or is it 3 numbers per pixel? How are they stored? Is a bigger number white, or is it black? What other things does the output device need? Will the image display be consistent? And the fundamental question is, whatever did we do before we had DICOM? DICOM defines all of these things today, but before DICOM, it was the Wild West out there in trying to get a digital image displayed on an output device. There were proprietary, unique interfaces from one device to another just so you could get the image to get to the display. Life has gotten a lot simpler since DICOM. You also have a question on the other side. Is there a sweet spot? Right? We talked about contrast resolution, spatial resolution, dynamic range, temporal sensitivity we didn't talk about, but things like flicker. How should we display this image so that the interface is the best between the image and the eye-brain system of the observer? We can say some things about that by looking at a chart like this. It's called a Campbell-Robson contrast sensitivity function. And it displays from left to right spatial frequency, going from low on the left to high on the right, and contrast on the vertical dimension, going from high contrast at the bottom to low contrast at top. And if you look at this, if you stare at it long enough, you'll see a curve that looks something like this. Each person will see a different curve because our visual systems are all different. But roughly, you'll see conceptually something like this. You will see that at very high frequencies, we can't see anything anymore. High spatial frequencies. Our eye-brain system just can't do it. The same is true at very low frequencies. We don't perceive very low frequencies. We also don't perceive very low contrast. You already saw that when I showed you some of the earlier pictures in this webinar. So there is, when we look at the characteristics of the human visual system, there is a sweet spot when it comes to contrast and spatial resolution, as well as other parameters that we're not going to talk about. And you have to make sure, however you do it, with image processing or display characteristics, that any medical image that's destined for a human viewer has to land or be made to land in the region where the human visual system works the best. So that's an important point. We need to make sure that the human visual or the human observer can extract from the image the information that's needed for the task at hand. I'll look at one aspect here, the vertical axis that we had on the previous image having to do with contrast sensitivity. The response of the human visual system is both adaptive and nonlinear. So the total dynamic range with adaptation of your eye-brain system is about 13 orders of magnitude. It's huge. Of course, you can't see all of that at once. Your eye adapts to the local ambient light. So we're very poor at determining absolute luminance, but we're very good at detecting luminance differences. That has an impact on the design of displays. In other words, how many bits do we need in our display so that we avoid problems like those in the image shown on the right, where we have these stair-step structures in a region that's actually, that we know has to be smooth. And it's also true that the same luminance change, delta L as it's called, is easier to see at low luminance than at high luminance. So we can do an experiment to figure out what the contrast sensitivity of the human visual system is. And the experiment works as follows. we measure something called just noticeable differences, JNDs, in threshold luminance at different luminance levels. And there are lots of factors that affect the results of such experiments, including the age of the observer and the size of the target and a bunch of other things. So I'm not going to go into detail there, but conceptually, this is what happens. We have some adapting luminance, that's the luminance of the room around you. Then we have a field that has some luminance L, and inside that field we put a target. In this case I've made it a circle. I'll show you what it looks like in real life in a minute. And we vary the luminance of that target relative to the field luminance that's its background. And we ask the observer, do you see the target? So in this case it's fairly easy. If we make the difference a little smaller, then it gets harder. And at some point the observer won't see the difference anymore. Now real experiments look more like this. They tend to use sine wave gratings, and they project those onto a screen with different levels of luminance, and the observer presses a button that says, okay, I saw it, and then they measure basically what is the threshold luminance at this particular value L, and we change L, and then we go do it again, and we do all of those experiments and produce a curve like the one that you see on the bottom, where the JNDs are plotted on the x-axis and the luminance changes are plotted on the y-axis, going from dark to light. Knowing what the just noticeable differences are, we can construct a scale, a perceptually linear scale, using a staircase of those JNDs. And we need only enough of those levels to fool the human visual system into thinking that the output is continuous. So we have something that looks like that, little stair steps that are small in the dark region and bigger in the light region. And the number of steps we need there, typically in the hundreds, is the number of levels we need in our output device when we're looking at images, so that the human visual observer won't notice any contouring, any steps in the output. There are a number of ways to do that, but they all basically use the available bits in the display most efficiently, assuming, of course, that your display is properly calibrated. DICOM has selected one of those ways to define this output luminance characteristic. It's called the Grayscale Standard Display Function, the GSDF, and you can see what that looks like in the graph on the lower right, where we have JND index going from left to right and luminance going from dark to light, going from bottom to top. Every output device, be it laser printer or iPhone or iPad or 5-megapixel monitor, has a defined luminance range, a minimum luminance and a maximum luminance that you can produce from that device. When we calibrate for a human visual observer, we have to include the ambient light. If you calibrate your iPad in your office to the DICOM Grayscale Standard Display Function, and then take it out to the beach or to the movies, you're no longer calibrated. So this ambient light piece is an important one because it changes our contrast sensitivity so that there may be things that we won't see under different lighting conditions. In any event, these limits, these luminance limits for the device, including the ambient, define an available JND range. So if we come in on the left side of this graph, there's the maximum value including the ambient, there's the minimum value including the ambient, and those, where they intersect the Grayscale Standard Display Function, define a maximum and a minimum J&D that we can use, J&D index. That's the highly coveted p-value that you may have heard about. Those p-values describe perceptually linear output devices. There's one more piece of the puzzle that we haven't talked about too much yet, and that's the observer sitting at the end of the chain. That observer also comes with problems that we need to think about. There's a radiologist in the U.S. named Harold Condell who spent practically his entire career investigating the question, why do radiologists make mistakes? And his results are truly amazing. And he's done a lot of work that's fed much of the research that's going on today into observer performance. One of his earliest results, he showed images to radiologists, did eye tracking studies on them, and this was like 40 years ago when he first started, so the equipment to do those kinds of experiments was not all that sophisticated compared to today. But he came up with some very interesting results, which I've got there on the top of the screen. There are three sources of error for the observer. One of them is visual scanning, which contributes 15% of the total errors. Visual scanning refers to how a radiologist looks at an image. He or she scans the image for targets, and if you look at some of the maps that come out of the eye tracking studies, it's amazing and a little scary how much of the image is never even looked at. And if they don't look at the target that they need to look at for this particular task, that's a visual scanning error. The second source of errors is target recognition. This means that the visual scanning process has been such that the eyes have crossed the target. They've dwelled on the target, but they didn't recognize it as a target. So it just went over them, went past, and went on to the next one. Those two sources of error were more than half of the total errors. The third piece is decision-making and interpretation. This is the case where the radiologist has scanned the target, has recognized it as a target, but then has dismissed it as being unimportant or irrelevant. That's almost half the errors. In addition, there are other sources of noise, other sources of variability in this process, namely inter-observer and intra-observer variation. The inter-observer variation is the one where radiologist A says it's a nodule and radiologist B says it isn't. And so they don't disagree, or they don't agree with each other on the characteristics of the target and the meaning. And then there's intra-observer variation. That's the radiologist early in the morning, fresh in the clinic, versus at 6 o'clock at night, making decisions about the same image and coming up with different conclusions. The error rate, of course, is task-dependent. So the error rate in mammography might be different from the error rate in chest, or even within chest, looking for lung nodules versus pneumothorax or whatever. So you need to take that into account as well. But it brings up a basic question. If more than half of the radiologist errors are due to visual scanning and target recognition, if we could make better images, higher quality images, or higher quality imaging systems, would we make better radiologists? Can we improve radiologist performance by tweaking our imaging system, by improving it in some way? To look at that question, I've plotted here various technologies since 1895, since Röntgen's discovery of X-rays, both analog and digital. So it's got a very long history and a large collection of different technologies. And if you look at what's happened from a technology point of view, there have been significant image quality changes over that period of time. There have been significant dose changes over that period of time, factors of 50 or 100. If I now try to characterize the performance of radiologists, let's say experienced radiologists, over that same period of time, you get a graph that looks like this. Within some band of errors, some band of variation, there hasn't been a lot of change. The first experiments to measure radiologists' performance were in 1955. Those were Garland and Yerushalmi who did those experiments. That was, at the time, a scary paper because it showed that radiologists were not infallible, that they made errors, and significant errors. And that started the whole field going, trying to measure performance and how to improve performance. But what you see is, with all the various technologies that have come on since, the change has been relatively minimal. There's not much correlation to technology. So there are two ways to interpret that. One of them is that radiologists are at a skill level that they can locate relevant clinical image information consistently, independent of any image quality change. And if you go back and look at the old days when films used to come out of processors, the quality, image quality of some of those films was, to put it mildly, atrocious. And yet, radiologists were able to look at those images and make correct diagnoses. So there's something here that has an element of truth in it. The conclusion here would be that the imaging system is the limiting factor. If we could push the image quality of that imaging system higher, then we might even be able to raise the performance level of radiologists. The other possible conclusion, as a result of this relatively constant error rate, is that imaging system manufacturers are wasting their time trying to maintain or improve image quality because the end users can't or don't use it clinically. So in this case, the performance limit would be the radiologist and not the imaging system. It's the observer that's the limiting factor in the chain. If in fact it's the imaging system, there are lots of new capture technologies coming out, tomosynthesis being an example, new image processing algorithms, better display technologies, higher luminances, all with higher objective image quality characteristics. If it's the radiologist who's the limiting factor, in recent years, decision support systems have come into vogue. Computer-aided detection, computer-aided diagnosis, that help radiologists do their job, and successfully have helped radiologists do their job. Given that there are improvements on both sides of the argument, the next question is, where does the curve go? Does it stay flat? Do the error rates go up because all of a sudden radiologists are seeing things they hadn't seen before and are now confused? Do the error rates go down because everything becomes clear now? This is what I missed before, but now that I have this higher quality imaging system, I know what I was missing, and therefore my error rate goes down. or do we stay on the straight line? The research that's gone on in recent years is pointing towards the radiologist as the limiting factor at the end of that imaging chain. And there's lots of work in particular on this area of decision support systems, computer-aided detection, computer-aided diagnosis, to try to characterize the performance limits and figure out where one can use software, where one can use algorithms to improve the results. Equally, things like tomosynthesis are now creating quite a stir, particularly in mammography, but also in chest, with the ability to see slices in sort of like a CT format, but not completely CT. So both sides are getting improvements. The conclusion is that you shouldn't overemphasize the importance of objective image quality. People tend to do that. You will often see the battles between the manufacturers yelling at each other, saying, my DQE is bigger than your DQE. Yes, DQE is important. It's a good metric for objective image quality, but it's not everything. The observer can play an equally important role in the entire imaging chain, and we shouldn't forget that. So we come to the summary. There's no image quality. There are 3 image qualities, and unfortunately they're relatively uncorrelated, so we need to study each of them individually: objective, subjective, performance-based. So when you talk about image quality with someone, make sure you know which of those 3 you're talking about. There are familiar metrics that we all use every day when we look at images: contrast, sharpness, and noise, that play a role in all 3 of these types of image quality. So if we go back to the fundamental question that we asked at the beginning, does image quality matter? The answer is yes. So all of those of you who raised your hands in front of your monitors, you're right. But we should not overemphasize the importance of objective image quality. Remember, we can create poor images with a good detector, and we can create poor images, good images from a poor detector. But more importantly, don't underestimate the role of the observer in determining the success or failure of an imaging chain. So we've covered all of this material at a fairly high level. It is indeed possible to go far deeper into the subject, which I won't do today, especially since we're running out of time. And with that, I guess I will just thank you for your attention, wherever you are out there, and turn it back over to Jim.
Again, I want to thank you for presenting. It's very, very knowledgeable and very informative.
Thank you. My pleasure.